Yeah, Dr. Wakelee, do you have any comments? You're on mute. You're on
I
mute.
figured that. Yes, I'm no longer on mute, but I was on mute.
Mm.
There's so much happening in this space, and I think where it gets confusing is as Professor Liu was talking about, you have the ADCs, and they're targeted and not, right? And so when we have ADCs that are truly targeted, and right now the trastuzumab deruxtecan really is the best example, then it's just so exciting. And it sets our expectations for these very, very high responses and long durability of response, like we see with the targeted tyrosine kinase drugs. And yet, when we think about our other antibody-based therapies, whether it's just antibodies like a PD-1 inhibitor or the ADCs or the bispecifics, we really haven't quite gotten to that level of specificity, right? Where we can really recognize what the antibody's recognizing and plan ahead to find the right patients and use the medications. And so as we think about this, just a plethora, so many new drugs coming available, and yet how many of them are really taking advantage of the antibody in a way where we can test ahead of time and know who to give it to, and how many of them are just bringing another drug. I think that's where we grapple, and it's hardest with some of the newer targets like the TROP2, where maybe we just haven't tested correctly. And if we test the right way, we can see things the way the antibody sees it and find the patients ahead of time where that treatment is going to work. But right now it's sort of a little bit blind, right? We can say, oh, it's EGFR more, but I don't think we really fully understand that. And we also bring in more toxicities as we bring in more potent drugs and other combinations. So it's happening very quickly, which is so exciting when we think about where this is our 2025 year in review. If we go back 20 years, we had like one or two new things. I mean, that was the EGFR world, right? It was very exciting, but it was one or two things. And then it's been sort of faster and faster and faster and faster and faster. And I think we need to keep that caution of recognizing when is something new really helping us move forward and what we can offer patients versus diluting, because there's so many things out there. It's hard to know what's really the right thing for each patient. So I reflect on that some as we hear about the amazing developments with the ADCs, which have been really transformative in some ways, but also for those people who haven't been in practice as long, some of the ADCs, it's like rediscovering irinotecan, which is a great drug that we stopped using, right? And so we have to keep working towards how do we make it truly better. And some of the immune approaches are truly doing that, and some I don't know. So, but it's exciting, right? And there's just so much. And when we think about some of the pathways and we understand like HER2, and we see everything that's developing there, it's truly phenomenal. And then we think about, I've actually had a number of patients right now with NRG1. I don't know why they all have come in the last few weeks, but we have many. And, like a small target, it's rare. And now we have a drug, but it doesn't necessarily work as well or as long as we would like. And so how do we keep focusing on these tiny niche diseases while we also kind of think about what are we actually going to do that's going to be transformative again? So